Bismillahirrahmanirrahim. Pediatric vascular surgery, pediatric vascular injuries is their role for conservative management. Vascular injuries in children are a great challenge for the treating surgeon in terms of diagnostics, operative treatment, and perioperative management due to low incidence and specific anatomic and physiological characteristics. Pediatric vascular trauma has not been extensively studied, and there is no consensus for optimal management because of the limited data, and the guidelines for treatment are lacking. Also, limited experience by most surgeons. Vascular injuries in children are characterized by small and 𝗘𝗏𝗡 vessels, poor tissue support, pronounced tendency to vascular spasm. Additionally, the small intravascular volume is of great importance in the treatment of pediatric vascular lesions, as perioperative blood loss can be of grave outcomes even if considered minimal. Classification either regarding the cause, traumatic or iatrogenic, regarding the site, trunk or limb. The current studies, the most injured vessels was the femoral artery 25% and the brachial artery 22.7%. The mechanism of injury was penetrating, isolated, severe blunt, multiple trauma, and humerus supracondylar fractures. Humerus supracondylar fracture, where the brachial artery is liable for injury by the displaced proximal segment. This algorithm is especially for the pink pulseless hand, patients with absent pulsations. In short, perfused cases of fractures with absent peripheral pulsations can be managed conservatively, and in many cases the pulses were restored, while in perfused cases primary repair, while in non-perfused cases primary repair or interposition graft using basilic or greater saphenous vein is the usual management. In rare cases, electrocution can cause massive damage, which may necessitate mutilating measures. Iatrogenic lesions make up to 1/3 of vascular injuries. Intra-arterial injections. Injuries are caused by accidental injection into an established arterial cannula, inadvertent and unrecognized cannulation of an artery instead of a vein. Accidental intra-arterial injection of medications has been increasingly reported. Although many medications have been injected into arteries without significant consequence, a number of drugs are consistently associated with severe morbidity, including need for amputation. Making early incident recognition and treatment is vital. Benzodiazepines and penicillin-based drugs were the most commonly identified drugs with severe complications such as gangrene. Optimal treatment modalities are still uncertain. Regimens include anticoagulation and intra-arterial injection of thrombolytics, and prostaglandins may improve outcomes. Steroid, vasodilators, and sympathetic blocks do not appear to influence amputation rates. The femoral artery iatrogenic injury complicates the course of critically ill neonates and children. Complications from cardiac catheter procedures as PDA closures and other, resulting in arterial thrombosis. Complications from persistent arterial occlusion may include claudication and limb length discrepancies. In many cases, patients with claudications respond to conservative treatment. Severe cases may result in limb loss. Management is usually by thrombolysis followed by anticoagulation. Truncal vascular injuries occur infrequently and have a reported mortality rate of 30 to 50%. In cases with hemodynamic instability, operative management is mandatory. Many factors must be considered in dealing with this patient population. Vessels of smaller caliber, higher propensity for spasm, risk of infection, children's capability to rapidly develop collateral circulation, inevitability of growth, which is a condyle limiting, strong tendency for stenosis and growth arrest to occur. Whether open versus endovascular repair, the future somatic growth is a critical limiting factor for the wide adoption of endovascular techniques for pediatric vascular surgery. Surgical repair can be performed in school-aged children as in adults. The use of prosthetic conduits and homografts in these cases is limited. Revascularization with autogenous conduits as saphenous vein and basilic vein, interrupted suture lines, and generous patulation will enhance the durability of anastomosis and limit future stenosis from a purse ring effect. In contrast to neonates and In contrast to neonates, we usually conserve giving them in contrast to neonates and infant, children less than 3 years and 12 kilograms, systemic heparinization is an alternative safe method, and limb loss is rare. Whether management is non-operative primary repair patch interposition graft, what are the challenges determining proper care in field with limited ability to collect prospective uniform data? Amputation, we have a significant problem of osseous overgrowth leading to skin perforation and repeated revisions. We must preserve length, perform disarticulation rather than transosseous amputation whenever possible, preserve knee joint whenever possible. Vascular surgery residents less exposed to open vascular surgery, and vascular surgery residents rarely exposed to pediatric surgery. The rise of integrated vascular surgery residency, training, and more exposure to open vascular surgical procedure, general and pediatric surgery, the management of pediatric vascular trauma in children's hospital by a dedicated vascular team. Thank you.